Good morning, everybody. Thank you for coming to this lecture. I would like to first thank the president of this meeting and the organizing committee for allowing me to present something I work with and I like very much, which is liver transplantation in children. I will lecture today about living donation and the results of living donation. And I will start with some background of history and the role and the contribution in the world. So historical landmark first. The very first transplantation from a living donor were done in 89, both in Brazil and in Australia. This was Dr. Raya and Dr. Strong who did the first case. There were not many cases after in Brazil, but the story made that expanding quite well in Australia. But more important is that immediately after 89, 90, a big program started both in America and in Japan. In Japan, because there was no other option for transplantation, and as a pilot study dominated by Bruch in Chicago, who at that time for 5-10 years was the leader in one of the leader in the world. You can see that just 5 years after, not only America and Brazil and Australia, but another few countries like Belgium, Germany, also Turkey and Japan was working. Very quickly it expanded because the story of living donation is a success story. So you can see that rapidly by 2000, a few other countries like Canada, Sweden, France, Spain, Italy, and other countries in the world have been starting. Nowadays, you can see that most countries, more developed countries, most countries where there is a transplant program or hepatobiliary surgery are able to provide a living donation for some patient. What has been the contribution of this activity to the transplantation in children? I will not speak about the contribution in adult. My talk is dedicated to children. The first is that in countries where there was no option for donation from a deceased donor, like Japan, you can see that their activity developed very rapidly between the 90 and 2000, and then has been a plateau around 400, 500 cases per year, where you can see a stable number of pediatric transplantation, but also a large part of adult living related donation for transplantation. And only in the last 10 years, because of really a pressure for developing any other source of transplantation and or any type of donor, they've been introducing slowly, but a very small amount of deceased donor because there is also a limit in living donation. This is the contrary. This is the presentation of America, UNOS database. You can see that in America, the particularity is that they have for children quite a large amount of donation. Although you can see that slowly in time, and I will come back to that in the conclusion of my talk, you can see that slowly the number of pediatric donors is going down. But because they have this huge number, this is just exceptional in the world because they are the only country with that much of pediatric donors. You can see that they mostly do liver transplant in children from deceased donor. And the activity of living donation remains something like 10% stable from 2000 and 2006. So there is no big change, but the presentation of transplantation in America is completely different to the rest of the world because they have this large pool of donors. If we come to Europe, you can see that in the past, 30 years ago, most transplants were with full-size liver donors from full-size livers from a deceased donor, but with time there's been a drop in the number. As the number of transplants were increasing, this source of full-size liver was not enough, and today, in the last 10 years, the number of full-size represent only 20% of the whole activity of transplantation in children. If we go inside this technical variant, we can see that reduced liver was very expanded 20 years ago. It has been replaced by split graft. But you can see that the activity of living donor is rising from the year 90, so 30 years of activity, continuously growing and represent now 40% of the technical innovation. So globally, we have 20% of full size, 40% of living donation, and 30% of split graft for children. Advantage of liver transplantation in children compared to disease. Of course, I will not say there is an advantage, so we should do all living donation. This is an advantage simply theoretically to show that this is a good product, good value for the children, and it solves some of their problems. So we should consider it, even if you do a lot of cadaveric transplant. This is an option and an alternative that can save many lives. The first is that this is the best operation timing. If you have an urgent child and you put him on the list, he has to wait for a liver graft. With the living donation, you can organize, you can prepare your patient, you can make the condition of the child better, and you can time the operation when the child is ready and turn an urgent operation into an elective operation. This is also an opportunity for best matching. We know that the donors are very often the father or the mother, so there is half of the HLA which is matched, which is something we never achieve with other donors. There is also a good matching about the size of the graft, and I will come back to that later in the talk. And as I said, this is an elective planning, so it means surgeons are not working during the night in another hospital. This is an operation that is planned at 7 in the morning, and you do during the day in a very good manner, because you are in your hospital and you have all your usual tools at your end. This is also a very adaptable technique. I will come back to that. You can achieve an optimal hemostasis because you are working in the donor, and the graft that arrives in the abdomen of the recipient has no bleeding at unclamping. This is very important as well to spare transfusion in the recipient, and we know that sparing transfusion allows a better outcome. And to finish, this allows, of course, a shorter ischemic time because you have in your own hospital on one room the donor, in the other room the recipient. You can get a very short ischemic time of a few hours only, or even less sometime. And, of course, all of that make that the graft has an optimal function. Coming back a little bit to the strategy and the technique, the advantage is that you can procure an optimal graft for transplantation. It means that you can know, because you have an elective operation and you have the donor in your hands before you do the operation, you can study the anatomy of both your donor and your recipient. When you have a recipient who is difficult because he has anatomical variation, because he may be a polysplenia and has malformation of the portal system, the cava, and so on, you can plan your operation. Second, you can also plan further your operation in that you can adjust the volume you need by taking a little bit more or a little bit less from the donor, and you know it in advance, and you can really match the volume to the need and sometimes to the abdomen of your recipient. If you have only a 4-kilo patient, you can plan to just procure a very small graft from the donor, and you do all of that during the same operation. So this is the typical setup and the typical assessment we would do in a donor. We would look at the volumetry. We can calculate segment 2, 3, or segment 2, 3, and 4. We can also calculate only the volume of segment 2. We can assess in much detail the anatomy of the arterial and the portal system. And if in this case you see that there is an artery for segment 2 and 3 and a separate artery for segment 4. So if you want to take segment 2, 3, and 4, you know you will have two reconstruction. You know about the biliary system and the variation. You know how many anastomosis you can do or you may have to do. And you can also plan, if you want, to procure the liver and dividing the bile duct where there is a single bile duct instead of having two anastomosis. And with the MEVIS system or the system, you can build. You can analyze the liver and the technique. When you have a difficult case, you can go into very much detail. And for example, for a very small child, if you want to take a reduced left lobe, or what some people call a monosegment, you can go into detail in the anatomy to see or you can achieve a very small graft taking only segment 2. These are things you cannot do if you do a split in situ during the night in another hospital. So this is the typical graft that we use in children. For most children, 2/3, even 80% of the children get this graft, which is the left lobe, segment 2 and segment 3. This is a standard called left lateral segment by the American. His weight is usually 200, 300 grams, but it can go to 350 or 400 in some donors. But this is the anatomy of the graft. If you do that in a cadaveric donor in situ during the night, this is the graft you get, because you would not go to make things more complicated. But if you have a living donor, you can, for example, expand. If you have a child with 30 kilo as a recipient, you may want to have 400 grams, and then you can take segment 2, segment 3, and segment 4. You see, this is the umbilical ligament. So segment 4, but not the median hepatic vein, has been procured in order to get a bigger graft. You can also, in the donor, during the operation, you can also reduce this left lobe and go to what people call a monosegment. I prefer to call it a reduced left lobe. And you can see that the dark side of this, the dark part of this left lobe is the one that have been resected during the donor operation and taken off, and it is dark because it was not perfused. And this is the graft, and you can see that the graft was reduced to something like 100, 120 grams, and it fits well the very small recipient. This is the concept. You have the standard left lobe, the standard split graft, or the standard graft we procure from living donors. It goes very well to children between 5 and 20 kilo. But if you want to refine and if you want to increase the chance of success, you can make it much smaller for the children who are 3, 4, 5 kilo. And you see this is 100 grams, and it fits very small abdomens. And this is the same graft that you just reduce. And if you want to transplant safely with less risk of dysfunction or a small graft syndrome, you can take a little bit more, and then you can go safely to 35 kilo for the recipient. These are things you can do, and you see that we find that in the registry from Japan or from Europe, you can see that most of the left lateral segment used for living donation, segment 2 and 3, are 70% and 70% in both registries. And you can see that the left lobe, which is segment 2, 3, and 4, so the larger graft, represent 20%, 23%. So these are more or less the need we have in children. The children who are a little bit higher, 25, 30 kilo, are less than the children who are lower than 20 kilo. And the less than 20 kilo, they can adapt very well with the standard graft. And there are also the reduced liver. In Europe, we don't have that number, but you can see that in Japan, they register in the register when there is a reduced liver, and you see that 4% of this graft in children have been hyper reduced to the very small graft I've shown you. What are the results? This is the first couple of results from America first, because they have been studying recently, and you see that this is a series up to 216. I don't have detail for many registries, so I start with this one. You can see that they demonstrate very nicely that the living graft, so the graft procured from a living donor, has a better survival significantly compared to other type of grafts. And you can see that, of course, if you look on patient survival, although some of these patients who have lost this graft have been transplanted and have been surviving, there is still some significant, quite significant difference if you receive as a first graft a graft from a living donor compared to other. If we go to Europe, in the last 10 years, this is 2010 to 2017, you can see that the survival of the grafts are equal independently if they are full size, if they are split from a deceased donor, or if they are from a living donation. You can see that's exactly the same curve. 5 years survival is close to 80% for the graft, independently of the origin. That is a little bit surprising when you compare that to America. But remember that in America, they do very little activity of living donation, so maybe the selection is much different. In Europe, we are depending of living donation to do the urgent case. And the second aspect is that not every center in Europe is doing living donation. There are just a few champions like Belgium, France, Germany, Italy, Poland, Spain, Turkey, and UK. And many other centers, they just don't do, they do very little. So that may be a problem. If you do a lot, you may have good results, but Europe and the registry of Europe is pooling a lot of centers who are doing very small activities. And you can see that here, there are 53 centers who do less than 5 living donor per year. There are 9 centers who do 5 to 10, and there are 6 centers only who do on a regular interval more than 10 living donation per center. And this might impact the result, because if you look at the result for living donation grafts in centers who are doing less than 5, a few ones per year, or more than 5 and more than 10, you can see that there is a very significant difference in terms of survival. So in Europe, there may be, because there are a lot of centers who are doing very small number of living donation with a not as good outcome compared to the one who are doing a lot of transplant from living donors. This may just flatten the curve for living donation, and we would expect that in Europe, if you go to the big centers, you would get a different picture. You would get a better survival. Like, for example, in Canada. In Canada, this is a single center, very good center, doing a lot of transplant, a lot of deceased donor, but a lot of living donation. And these are the results. Oh, sorry. Sorry for that. Coming back. So you can see that the 1-year survival is 97%, the 10-year survival, and this is very typical of living donation. The curve is very flat. It's not a curve, it's a flattened survival at the long term. They have 94% at 5 years, they have 94% at 10 years. So this is one of the quality of living donation. And again, in a single center, doing the same operation with the same type of graft, if the donor is living or deceased, there is a difference. And the difference is the quality of the donor. The living donor is an optimal, healthy donor that has been checked on every aspect, while the deceased donor has been through death, has been in ITU, maybe infected, and you know that you have an ischemic time which is longer. So you would expect this type of results. This is another series that comes to 2014 from Brussels. Lot of living donors, 250. Lot of activity every year. So an expert group, and you see 1-year survival 96, 10-year survival nearly the same, 93%. So there is definitely a gain. This is another single center, which is mine, my activity in the last 10-15 years. You can see that even if you are on the very high survival, there is still a difference, a small difference between the living donor and the postmortem. And you can see that we are close now to 10 years and the curve is just the same. Safety for the donor is, of course, an important aspect. This is something which is probably the most important when you look at living donation. You would not imagine putting donors at risk, so the selection is very important. We do, for example, on a regular basis, we assess both the father and the mother. But overall, we would reject 40–50% of the donor we are assessing for anything that increase their risks. So it may be the anatomy, it may be that they have hypothyroidism, it may be they have a problem with the lung, or it may be that they are heavy smoker and they cannot quit. Very often, we would refuse the people who have a BMI over 28, 27, 28, or we would ask them to lose weight, and they do. I mean, this is a very good incentive to lose weight or to stop smoking, when you know you can be a donor for your child, that is a very good incentive. And I've seen people losing 15, 20 kilo easily when they were not able to lose any kilo in the past. So what are the complications? If you have this good screening and selection of donor, you would expect a mortality of 0%. With the left lobe procurement, of course, there are some major problems and some death described in the world, but you would expect to be extremely close to zero. The report of death after living donation for a child is very rare in the literature. In this series of 80 consecutive living donors I did in the last 10 years, mortality was zero, reoperation rate was zero, transfusion, nearly nobody was transfused, only 1 unit in a patient after the operation because she had an hemorrhage after the drain removal. In fact, the drain was removed when she was under anticoagulation and she bled. She needed 1 unit, but nobody else has been transfused. Morbidity is mostly minor, like gastritis, temporary biliary fistula, very rare incident, epigastralgia, cephalae, and cholestatic syndrome, not due to surgery, but due to the anticoagulation therapy. That is a side effect I discovered with the living donor, and I didn't know before. So you stop Clexane and they become just normal. Two major problems, one hemorrhage, as I said, and a right lung atelectasia in a donor, in a female, who did not say she was smoking and she was a heavy smoker. She succeeded in avoiding, we knew she was smoking, and she had right lung atelectasia needing fibroscopy, but nothing else. She went well after. What are the perspectives for the future? So we know that in children, the epidemiology of liver disease makes that most of the demand for transplantation is concentrated in the small children, less than 5, and even more, less than 2 or 3 years of age, where are concentrated most of the biliary atresia patients, some metabolic disease. The organ demand is thus for the small children, and worse, they are also very sick, so they may not grow. So the demand for organ is the most important in children less than 12 kilos. If you look at that and you know that we have a liver graft shortage from deceased donor, you would expect that these children have a prolonged waiting time, that during the time of waiting, they are deteriorating from a clinical point of view. They may decompensate their liver, they may have ascites that is refractory and so on. Some people may die. Some of these patients die on the list. Sorry for the mistake on the paper there. And if they are transplanted in poor condition, you would expect morbidity and mortality be higher after transplant compared to children who would be transplanted in a good condition. Coming back to UNOS database in America, you can see that this is the median waiting time for list in list for pediatric transplantation. You can see that at 3 months, many patients are still on the list because their waiting time is much longer than that. You can see that there has been a trend for improvement during the years because in red you have 2003 and 6, then you have up to 2010, and you have the more recent era, the group 2011, 2014. You can see that most of the children, the mean waiting time is above 3 months for any child on the list. Parallelly, you would have, of course, mortality on the list, and you can see that in America, despite the fact that things have been improving with time, for the children who are registered on the list before the 1 year of age, the percentage who are dying on the list is still very high, and last information I have was, sorry for that, was that it is around 17% even in last year. So high rate of death on the list under 1 year, and there is a 5% risk of dying for other patients who are older. On the allocation side, what happened also is that you can see on the right side is that the number of patients who receive a transplant only because they have been put with an exception as a priority on the list is rising. More than 60% of the patients get transplanted when they are an exception, a priority on the list. And that's not a good news because it means that if 60% of the children are transplanted because they are on the priority list, it means that if you are not in the priority list, you never get transplanted. So that's not good news for them. Europe, you remember I said, and we confirmed, 2/3 of the transplant are done in children who are less than 6 years. You can see that nearly a large third of this group is represented by the less than 1 year, and 1/3 is over. if we go and look at the type of graft, so this is the patient who are on the first, on the left, you have children who are less than 1 year, then 1 to 6, then 6 to 12 years of transplant, and over 12. And these are the type of transplant, the graft we use. You can see that less than 1 year, 1/3 is living donor, 1/3 is split. If you go to 1 to 6, you see again 25% living, 30% split. And then you go to more full size if you get in older children. But you can see that in the children less than 6 years, who are representing 2/3 of the transplant, the use of a living donor is important to achieve good results. And good results, this is a result of Eurotransplant. Eurotransplant is not the registry of Europe, but it's part of Europe. And you can see that by having this access to split on a larger scale and living donation for 40% of the transplant, what has been achieved in the last 20 years is that we have been dropping the number of deaths on the waiting list that was not very high, because Eurotransplant is a lot, it's probably 120 million people, the countries of 120 million people. You can see that the numbers were very small, 7 patients per year in multiple countries. And you can see that this number has been nearly eliminated in the last 10 years. So this is a good achievement. And you can see that the difference is you have one country like America, they have a lot from deceased donor for children. But this is not enough. And they have a high mortality on the list, less than 1 year, for that reason, because living donation is used not very much. In Eurotransplant, we have the contrary. We use a lot of deceased donor for doing split, and we use living donation as an alternative. These achieve very good success of transplantation in the sense that there are not many patients dying on the list before the transplantation. In Japan, which is typically a country where you are missing all the deceased donor and that depends completely on the living donation, they introduce a deceased donor program. And this is the result of the last 10 years. You can see 122 patients who have been listed for deceased donor. And then this is the outcome. 25% only receive a deceased donor. And finally, because there was no donor allocated, 50% get a living donor to save their life. And their waiting list mortality is 3%. So you can see that if you have to wait for a deceased donor and you don't get it, your mortality is rising. But this is a better figure than what we have seen in UNOS, because it's only 3%, because they have the incentive to go for living donation when they see the child is not doing well. In Italy, part of Europe, the program has been for 20 years exceptionally rich of split. It means that there was an incentive and nearly an obligation to split, and the activity of Italy has been champion in split graft and avoiding nearly all death on the waiting list. But even in a country which has been organized for splitting graft and splitting, offering split to children at a high number, still, there are variations in the offer, and you can see that after 2006, the number of donors, pediatric donors, was going down. And the activity of donation, living donation, started to rise slowly. And in fact, this allowed to stabilize the number of transplants every year, because you can imagine that this was the top in 2006. They were going down very much in 2014. Then the system changed its allocation from incentive. There, it became obligatory. And again, the number of split graft was rising. But again, now, because the situation is changing, in Italy, they are also obliged. I'm sorry, I don't know why this goes around. Okay. Again, because the type of donor is changing, we get now more older donor, steatotic livers, deceased donor, I mean non-heart beating. Many of this type of donor are not good for split anymore. So again, Italy is going the way forward for introducing not much, but always a little bit more, living donation as a complementary alternative for transplantation, because if the number of good donors for split is decreasing, alternative for children, there are no other than living donation. So this is the double lane concept. If you are in a queue waiting for an organ and you have no alternative, this is queuing. Queuing means that some people and some cars, for example, will start having problem. No benzene anymore, and they stop and so on. If you have the double lane, it means that you are driving a normal speed, but there is always a possibility of going quicker, and there is a possibility of having an alternative. This is the way we should run in the future. Living donation is an important and useful, but it is a complementary, not competitive alternative for transplantation. I think that in the future, what we will see is that every good center doing a reasonable number of transplants will have to develop for children the two alternatives. And in fact, it is relatively easy because the technique we use for splitting livers are exactly the same that we use for living donation. In living donation, we can expand, we can go much more refined, we can do things that we would not do from a deceased donor. So we have even more opportunities and we can adjust better to the recipient. So this is the concept of the future. Any good center working on a large scale should have a double program, which is the deceased donor, because there is no reason we abandon the deceased donor, of course, but also a good program for living donation. Thank you very much for your attention.